who am I? Some of you know me, but for those who don't, I'm a physician scientist. So I spend approximately 80% of my time in the laboratory where I study mechanisms of blood clots in these diseases. And 20% of the time I work in the clinic seeing patients. I did my internal medicine residency at the Mayo Clinic in Rochester, Minnesota. And then for hematology fellowship, I went to the University of North Carolina at Chapel Hill because I was very interested in understanding how blood clots and bleeds. And my whole goal with that was to combine my research and clinical interest in MPN, which, as you know, have a big problem with both bleeding and clotting. And so I now lead the UNC MPN program, which may sound like a big title, except for a while it was only me. Now we have a slightly bigger program. So here's my team. There's a second doc, Hank Van Deventer. We have a nurse practitioner, Becky Salchuk. We have our own clinical pharmacist. We have a nurse navigator. We have new patient intake coordinators, and then we have return patient coordinators. So it's grown to be a pretty big program now with over 500 MPN patients concentrated in our clinic, and we're seeing about 100 new patients per year. So in this talk, I'm going to talk about the basics of polycythemia vera, just to kind of give you a background. And then we're going to talk about the treatment goals in polycythemia vera with a focus on the cell counts. And just kind of a show of hands here, how many of you have thought about cell counts other than hematocrit with your disease? Perfect. So some of you. And who in here has gotten conflicting data or advice from your physician about what your cell count target should be? Excellent, so about the same. So I was trying to, the purpose of this talk is to help demystify why we're saying what we're saying and what do these counts actually mean. Okay, so what is polycythemia vera? So as you know, we're talking about a group of chronic blood cancers called myeloproliferative neoplasms, or MPN. And there are 3 big types, and 4 since the prefibrotic myelofibrosis got thrown in. But those are polycythemia vera, which we shorten to PV. That is characterized nearly 100% by having a JAK2 mutation and having too many predominantly red blood cells, but also white blood cells and platelets. There's essential thrombocythemia, which we shorten to ET, and that's more of a mix. So about half of patients have a JAK2 mutation, about 30% will have a CALR or calreticulin mutation, and about 5% will have a MIPL mutation. And that's predominantly characterized by having too many platelets. And then there's primary myelofibrosis, or MF for short, and again has a spectrum of mutations, predominantly JAK2, but also calreticulin and MIPL. And in that case, the too many number of cells can be variable, so it can be too many platelets, too many white blood cells. It's typically low red blood cells, but it's sometimes also low platelets and low white blood cells. And it's really characterized by scarring in the bone marrow, a big spleen, and a lot of symptoms. Now, PV and ET can progress to myelofibrosis, in which case it's not primary myelofibrosis, it's considered secondary myelofibrosis, but they're very similar. And all of these diseases can ultimately progress to kind of the feared complication of acute myeloid leukemia, or AML. So what is myeloproliferation? So, you know, we talk about MPN, but what exactly do we mean? So we have these stem cells in our body, and our hematopoietic stem cells can differentiate into a myeloid lineage or a lymphoid lineage. And so in the myeloid lineage, we have the megakaryocytes, which are the parents of platelets. We have red blood cells, and then we have the non-lymphoid white blood cells. So if you see up there, most of our blood cells are going to be in the myeloid lineage. So I did mention it's a chronic blood cancer. So since 2005, we've known about the JAK2 mutation, which underlies many of these diseases. And so you may recall they used to be called myeloproliferative disorders, but then they got reclassified as myeloproliferative neoplasms, and they now fall under the cancer umbrella. And so our body likes to keep the number of blood cells in a very tight range because too few cells cause problems and too many cells cause problems. So the way it does this is it sends signals to the bone marrow, which is the factory that makes those blood cells, and it says, hey, I need more blood cells, or no, I'm good. And so when it sends those signals, there's a cell in the bone marrow that gets that signal, and then it produces the blood cell. So in this example, here's your signal to your bone marrow cell. In this case, it's erythropoietin, which is signaling for red blood cells. It docks in the receptor, and when that happens, it sets off a cascade of events that activates the cell predominantly through this JAK pathway that tells the cell to make more. In the case of a JAK2 mutation, you get an active cell without the signal from the body. So you're making too many blood cells without your body being asked. And it turns out that JAK2 signals not just for production of red blood cells, but also for white blood cells and platelets. Let's see, sorry, my animation is lagging just a little bit here. So in terms of polycythemia vera, why do we care? So many of you were told this is a chronic disease, you're going to live a decade plus with it, so why are we even all here, right? And the answer is, as you know as well as I do, that while you might live for a decade plus, there are a lot of risks with it, including the fact that about 2/3 of patients are symptomatic, and that can be pretty severe. And there is a reduced overall survival, even if it is measured at 13 years. So in terms of the clinical implications of PV, when we talk about symptoms, again, the majority of patients with PV have symptoms. And if you look, many of those symptoms, I'm sorry, it's really lagging. Many of those symptoms are actually fairly severe. So the light blue are mild symptoms here, and then the darker blues are more severe symptoms. And you'll notice that about 30+% of patients actually have moderate to severe symptoms with polycythemia vera. So certainly not undervalued here. There's a risk for thrombosis, which is, again, what I'm interested in. So about 1 in 5 will have had a thrombotic event by the time of their PV diagnosis, and that could be arterial, like a heart attack or a stroke, or venous, like blood clots in the legs, in the lungs, in the abdomen, or sometimes in the veins of the brain. And kind of surprisingly, about the same number of patients will have a blood clot even after their PV diagnosis. So I think we have a little bit of work to do there. There is progression to myelofibrosis and AML, as I mentioned. So about 1 in 5 will progress to myelofibrosis at 20 years, and about 1 in 10 will progress to an acute leukemia at 20 years. So again, it's not 100%, and we don't know how best to identify those patients yet, but there is certainly a risk there. And the big thing, there is reduced overall survival. So on the bottom in the red are the polycythemia vera survival curve as compared to the blue, which is in the general population. So you can see that those curves dramatically differ, and so there is reduced survival. Most of that reduced survival is related to blood clots in these patients. There are other implications of MPN which are less well known, but are starting to come to light. And one of those is chronic kidney disease. So where your kidneys don't filter as well as they should. And so there was a recent publication showing that about 20% of MPN patients actually have chronic kidney disease, and stage 3 is fairly significant chronic kidney disease as compared to 7% in the general population. So I kind of think about this on the spectrum of cardiovascular disease where your blood vessels are really attacked by having this mutation. Similarly, osteoarthritis, I found this publication really fascinating. So by radiograph, so x-rays, 70% of MPN patients have osteoarthritis in their hips or knees as compared to the general population where the prevalence is 10 to 15%. So you can imagine if you're diagnosed young with an MPN, you have a long time to develop these complications at a higher rate than the general population. So like Dr. Koltoff mentioned, I think we're now talking about more than just control of the blood cell counts, but thinking about how we can really impact the course of this disease. Okay, so let's talk a little bit about our treatment goals. So we obviously want to control symptoms, and I think we do a fair job at doing that. We want to reduce the risk of blood clots. We want to reduce or improve overall survival, and we do a fair job of doing that. And then there's a big question on, can we intervene in the progression to myelofibrosis or acute leukemia, which I think is a big question moving forward with a lot of promise behind it right now. So in terms of how we manage PV, we have classically divided this into low risk of thrombosis and high risk of thrombosis. And I want to tell you that low risk doesn't mean no risk. So low risk is classified as being under the age of 60 and never having had a blood clot. And so with that, your risk of a blood clot per year is roughly 3%. So that's 3 in 100 would develop a blood clot. And that's significantly higher than in the general population. And in low-risk patients, our standard approach, as you can see here from our National Comprehensive Cancer Network guidelines, is to manage cardiovascular risk factors, which is a whole nother soapbox because we don't actually have standard cardiovascular risk reduction protocols in MPN patients, to give a baby aspirin every day, and then phlebotomy to maintain hematocrit of less than 45%. So you heard from Dr. Ryan that the less than 45% is very important. And then if you need cytoreductive therapy, so if you're symptomatic or you've got a rising white blood cell count or rising platelet count, then we consider things like interferon or hydroxyurea or second-line ruxolitinib, a JAK inhibitor. Okay, for high-risk polycythemia vera, that's either you've aged into the club, so now you're over age 60, or you've joined the club because you got a blood clot. So in that case, the risk of blood clots is estimated at about 5 to 9% per year. And you'll see that our treatment goals are essentially the same. So what we're going to do is manage the hematocrit to less than 45%, give aspirin, and then also add cytoreductive therapy here. So that's when we're certainly talking about cytoreductive therapy. You see really nothing in the initial management about any cell counts other than the hematocrit, although if you look over to the inadequate or loss of response, there's mention of the rising white blood cell count, which is called leukocytosis, or a rising platelet count, which is called thrombocytosis. Okay, so then what is hematocrit and what is our goal hematocrit in PV? All right, so Dr. Ryan did such an excellent job at explaining this. What I'm going to go over is, so hematocrit is a measure of packed red cells in a volume. So in our blood, we have plasma, so that's the liquid portion of blood, and then we have cells, most of which are red blood cells. So if you let those sediment out, you'll get plasma on top and red blood cells on bottom. So in a normal situation, our hematocrit is roughly 40 to 45%, and our plasma is 55%. So of the blood volume, 45% are red blood cells, the rest of that is plasma. When you have increased red blood cells, your plasma volume decreases, so you end up with thicker blood. Does that make sense? Yes. So on the curve here, you can see the viscosity of water is very low, and the viscosity of plasma, your blood plasma, is just a little bit above that, but it's very flat as your hematocrit goes up. As in whole blood, where you're considering the cells in there, hematocrit really matters because the more red blood cells you have in that volume, right, the thicker that blood gets. And when that blood is thick, guess what? It's pushing out the white blood cells and platelets to interact with the blood vessels. And so anytime you give platelets a chance to interact with blood vessels a little bit more, then you're more likely to get a blood clot. So we think that's what's at least in some part playing a role into blood clots and the role of hematocrit here. Okay. So Dr. Ryan went over this. We know that less than 45% hematocrit protects from blood clot events. So there's a fourfold reduction in blood clots if you controlled your hematocrit to less than 45% versus 45 to 50%. And even though that seems like a very minor difference, if you remember from this curve, just a little increase in your hematocrit, this is almost an exponential increase in serum viscosity. So the blood thickness really goes up just with that little change in hematocrit. Okay, we know from studies outside of cyto-PV that hematocrit is also important. So from the REVEAL study, which many of the investigators here were involved with, we also see that hematocrit was important when it came to predicting the blood clot events. And then, like Dr. Ryan was mentioning, is there really a one-size-fits-all approach? Are women little men? And is hematocrit of less than 45% the goal for everyone? And many of us would suggest that no, women should have a lower hematocrit because they have a lower hematocrit to start, right? So that's 600 milliliters of less of blood that women have that Dr. Ryan was talking about equates to about 3% for hematocrit points. So then if you consider 45 is standard, then we would go down to 42%. So that's where the magic number comes from. As Dr. Ryan mentioned, there's no actual hard evidence behind this. This is all kind of science and inference, but many times women feel better at the lower hematocrit levels as well. All right, what about white blood cells? And so white blood cells are immune cells that the body uses to help fight off certain invaders like bacteria, viruses, and they can also help with wound healing. And there are multiple types, as you can see over here, with neutrophils being the most common. So on your blood cell count, you'll see a differential, and that differential is telling you the different types of white blood cells and the numbers of them. The white blood cells make up about 1% of the total cells in circulation, and the normal white blood cell count is generally less than 10. So it's usually between 3.5 to 10. So the REVEAL study it was a prospective observational study of over 2,000 polycythemia vera patients, looked to see whether the white blood cell count mattered in terms of blood clot risk. And lo and behold, they found that having a white blood cell count greater than 11, so we're talking very slightly increased above normal, was 2.5 times more likely to have a blood clot risk than if your white blood cell count was normal at less than 10. So it does look like there's some relationship here. This has shown up in multiple studies that white blood cell count matters. Now, but does reducing the white blood cell count actually reduce your blood clot risk? So we know it's associated moving forward, but what if we normalize it? And the answer is that that really hasn't been specifically evaluated, but we presume that it matters based on studies like the MAGIC PV study, where they were using ruxolitinib versus what was called best available therapy. And in those cases, there were less blood clotting events in the ruxolitinib-treated patients, and they had better blood cell count control. So their white cell counts were more normal than those in the best available therapy group. So again, we're making an inference. We don't have hard evidence, but it seems reasonable based on what we know. What about platelets? And this is one I think that's kind of most controversial. And how many of you were told that you need to normalize your platelet count? Yeah, I thought I'd get a few more responses there. Yeah, so a normal platelet count is a really big thing, especially in the community, and it's something that we in the MPN community talk about a lot. Do we really need to normalize a platelet cell count? So platelets are very small. They don't have a nucleus. And they carry around materials that primarily help with blood clotting. In the general population, platelets are implicated in cardiovascular disease. So the aspirin that we take is targeting something that's made by platelets, right? So it's an antiplatelet medication. In polycythemia vera and ET, the platelets are very active. And in the tiny little blood capillaries in the fingers and the eyes, around the heart and the brain, they can get together and release their contents. And those contents cause squeezing of the blood vessels called vasospasm, which is what can lead to the symptoms like erythromelalgia, migraine headaches, the ringing in the ears, that atypical chest pain that happens. And so it's natural to think, right, if platelets are known to be involved in cardiovascular disease and they're known to be involved in these issues in the small blood vessels, that platelet count probably matters. But it turns out that there have been several studies looking at this with a different answer. So in this big study called IPSIT thrombosis of about 900 patients, the platelet counts were not predictive of thrombosis. In a different registry data from anagrelide, a different drug treatment, again about 900 patients, the platelet counts at diagnosis were inversely related to thrombosis. So the higher your platelet count, the less likely you were to have a blood clot, and the more likely you were to have a bleed. But at follow-up, higher platelet counts associated with a blood clot. So, okay. And then in this other cohort, almost 800 patients, at diagnosis, the platelet count was not related to thrombosis, but at follow-up, higher platelet counts were associated with bleeding. So all over the map, no great data here to really support that the platelet count matters. We know that the higher the platelet count, especially as it gets above 1,000, which we also refer to as 1,000,000, you're more likely to have bleeding events. And at the really low platelet counts, so well less than 50, you're also more likely to have bleeding events. But what happens in the middle doesn't seem to be quite so important. The REVEAL study also looked at platelet counts. And interestingly, they also found a mixed bag. They found that platelet counts that were increased, so over 400, at the time of a clotting event, was associated with a clot risk. But if you looked at platelet counts over time, so over a year, elevated platelet counts were not associated with thrombosis. So again, the platelet count seems to be pretty weak in terms of being a predictor for blood clot risks. So is it really just about the cell counts though, right? So this JAK2 mutation is there. Does it do anything besides increase the number of cells? And the answer is absolutely, it does. So we know that JAK2 causes lots of cell programming to be off. So it actually activates neutrophils. So neutrophils normally kind of patrol the blood vessels, and they're looking for invaders, right? So they're there to fight off bacteria. And if they get a signal that says there's bacteria, they attach to a blood vessel and they go through it to get to the bacteria. It turns out that in PV, the neutrophils are activated so that they have the machinery to attach to the blood vessels even when they weren't asked to. And when that happens, they can kind of sit there and get even more activated and release their contents, which we call extracellular traps or neutrophil extracellular traps. We call them nets for short. And the nets contain lots of sticky stuff. It's like a spider web that can catch the blood as it's flowing and can create blood clots. They also have other activation pathways. So my group and collaborators have shown that they have increased hypoxia-inducible factor signaling. I don't know if any of you have gone to altitude, but you know as you're climbing and you go up, if there's a risk of blood clots. There's a risk of blood clots with flying, right? And so you can imagine then hypoxia is associated with increased risk of blood clots. So it's turning on genes that are acting like it's in a low oxygen environment that increase the risk. And one of those genes actually makes a protein called tissue factor. And you can see in this slide, on the top are neutrophils from healthy control patients, and on the bottom are neutrophils from a polycythemia vera patient. And this is stained for tissue factor, so the yellow is tissue factor. And tissue factor is the glue inside your blood vessels that when your blood vessel is exposed, so it's got a cut, that's the first thing that's there, and it's like super glue. So it's very sticky, and it helps seal up the clot very quickly, or the cut very quickly. And so you can imagine if you have tissue factor on your neutrophils, you're a lot more likely to have a blood clotting event than if you didn't have tissue factor on your neutrophils, which is the normal situation. So again, it's not just about the cell counts. And so we also know it's not just about the cell counts because we're learning about a condition called clonal hematopoiesis. So this is where you have a mutation, a JAK2 mutation in this case, but you don't have increased blood cell counts that meet criteria to be called polycythemia vera or ET. And so in this case, ischemic stroke risk is still increased by twofold versus those who don't have a JAK2 mutation. And we're talking, these mutations are under 1% of the total cells. So this mutation can have a pretty big impact on the risk of clotting. Similarly, we see increased risk in venous thrombosis, fourfold increase by just having the mutation, no increase in cell counts. And it increases the cardiovascular disease risk by about threefold. So again, I think we're starting to understand this is more than just about cell counts, even though obviously they're important with the therapies we currently have, and that we need to be moving kind of away from this paradigm of just targeting the cell counts and making that kind of peripherally normal, but really need to be thinking about how do we target the actual disease biology to improve outcomes. And so, again, conclusions, hematocrit control is very important, less than 45% if you're a man, ideally less than 42% in women. White blood cell count looks to increase the risk of blood clots. We don't know that reducing it really decreases that risk, but it makes sense. Platelet count, really all over the map, hasn't really been shown to be associated with blood clot risk. So at least in my practice, I don't aim to normalize blood cell counts. I'm really aiming to reduce your risk of bleeding and control symptoms. And then the changes in blood cell quality, not just the quantity or number of cells, is really important in this disease. And I think that's what we need to be targeting in the future. With that, if there's time for questions, I'll take any questions.
Thank you for that very much. Any questions?
Okay. I have a question about RDW. When you said quality of cell counts, or not counts, but quality. So how do you interpret rising RDW?
So RDW is red cell distribution width, and it's one of the parameters we get back on our blood cell counts. And so what that means is that you have some red blood cells that are smaller and some red blood cells that are bigger. And there's normally a ratio of those, and a rising RDW means that there's a bigger split in the size there. That can be because of things like hydroxyurea, which makes the red blood cells bigger. It can be because of iron deficiency from therapeutic phlebotomy, which makes some of the blood cells smaller. It's not clear that rising RDW by itself is a bad thing. It's just one of the parameters that we get back. And usually it's caused by something that we're doing to the disease. So either the iron deficiency or the hydroxyurea, but not really associated with thrombotic risk to my knowledge.
Any other questions at this time? Yes.
You spoke recently about the kidney and potential problems related to the kidney. Can you talk about that a little bit more?
Oh, I could talk about the kidney all day. Oh my gosh. So I got to tell you, I was embarrassed, actually. I don't know if Dr. Mesa is in the back still, but I had a clinical trial open, and I couldn't enroll patients because it required a kidney value that my patients were, I was like, their kidneys were too bad to go on the trial. And I was like, it wasn't just one, it was two and then three. And I was like, what's going on? And so I looked in the literature, and there had just been an article published on the rates of chronic kidney disease in this population. So we don't know a lot about it yet. So we know that myelofibrosis tends to be worse than polycythemia vera, but we don't really know what's causing it. I assume it's from small blood clots in the kidneys. There was a recent publication looking at kidney biopsies where patients with MPN had a biopsy done because they didn't know what was causing their chronic kidney disease. And if you compared those to people with chronic kidney disease who got biopsies for non-MPN reasons, there were more blood clots in the teeny tiny little blood vessels of the MPN kidneys. And so it makes sense, if this is a disease that has a lot of blood clots associated with it, that the tiny little blood vessels could be impacted. So actually, we just started a study to look at this. So we have mice with this JAK2 mutation, we can show that they have reduced kidney function as compared to healthy control mice. And we're starting to look to see whether we can see those tiny little blood clots and what we can do to impact that. But currently, we don't know.